Welcome everyone to our latest installment of our best practices for clinical care in the World Trade Center Health Program. And the topic for today is PTSD and adjustment disorder. Our speakers are Dr. Rebecca Rosen, who is a clinical associate professor with the NYU Grossman School of Medicine and is also mental health director at the World Trade Center Environmental Health Center at the New York City Health+Hospitals. Our other speaker is Dr. Peter Haugen, who's the director of mental health at the NYU Grossman School of Medicine in the World Trade Center Health Program Clinical Center of Excellence. And he's also a clinical instructor in the Department of Psychiatry with the NYU Grossman School of Medicine. So Dr. Rosen principally works with survivors in the program, and Dr. Haugen works principally with responders in the program. Disclaimer, the views expressed in this presentation are those of the speakers and don't necessarily reflect or represent the views of NIOSH CDC. Any use of trade names, commercial practices, or organizations does not imply endorsement by CDC and NIOSH, and any citations to websites external to CDC NIOSH does not constitute our endorsement. And then finally, we do have a disclosure. One of our planning committee members has a disclosure which has been mitigated. So that's been taken care of. And I also should mention that this webinar, as well as all of the webinars in this series, are based on articles, papers that were published in the Archives of Environmental and Occupational Medicine. Those are all available, open access, free of charge. There will be a link in the chat to access those articles. And also recordings of all of our previous webinars are also available on the internet, and a link to those will be provided. So CE credits are available also for all of the recordings. And with that, I am now going to pass the baton to our speakers, Drs. Rosen and Haugen. Take it away.
Thank you. Okay, so let's see. We've got some interactive fun for you folks today. Kiana, would you please launch the first poll? Okay, so while acute stress-related symptoms abated quickly for most individuals who experienced 9/11 exposure, for many others, the trauma of 9/11 caused an exacerbated psychiatric disorders and has had an enduring impact. True or false? So please submit your response. All right. And it looks like everybody got the question right. 100% correct. Indeed, that is true. September 11th, 2001, a terrorist attack was carried out on U.S. targets. As part of that, one plane hit the Pentagon in Washington, D.C., one plane crashed in Shanksville, Pennsylvania, and two planes hit World Trade Center Towers 1 and 2. The towers fell, and what ensued was an environmental and psychological disaster. 2,977 people died on that day, which includes 40 passengers and crew members in Shanksville, 184 at the Pentagon, and 2,753 in New York City. Roughly 83,000 people worked in rescue, recovery, and cleanup, and in New York City, an estimated 500,000 community members were exposed to it either on that day or in its aftermath. I want to speak about some categories of those impacted. These are by no means all of the subgroups of those exposed on 9/11, but I'm going to talk about a few of the subgroups because we will refer to them a number of times in this talk. Responders refers to a heterogeneous group of folks who provided critical services, rescue, recovery, and/or cleanup, both during and after the emergency. Traditional first responders include firefighters, law enforcement, EMS, and medical personnel. These are professionals who are trained in and whose main occupational task is first response in disaster situations. Non-traditional responders are utility workers, construction workers, cleanup laborers, as well as other professionals not trained for first response, but whose expertise and skill is sometimes called for in an emergency. This category also includes volunteers who worked in the recovery and cleanup efforts. Who are the community members? What we call the survivor population includes local residents, local workers, students, those in adult or child daycare, passersby, and some people who did cleanup work are also classified as survivors. This survivor group is as diverse as the entire population of New York City. A little bit about the impacted community. The World Trade Center towers, the construction of which began in 1968, sat in the midst of an active residential and working community. You will see that the dot there on the bottom left is a little dark dot. That is the site of the World Trade Center. The residential neighborhoods are as follows. To the west is an area known as Battery Park City, a large middle-income residential community. To the east, Chinatown, mostly lower to middle income building complexes such as NYCHA and Mitchell Lama buildings. And to the north, Tribeca, with former industrial spaces housing artists and with middle income Mitchell Lama housing as well. In terms of the working community, the towers were nestled in the vibrant financial Wall Street area with the New York stock and commodity exchanges, as well as countless offices and manufacturers. 50,000 people worked in the World Trade Center towers themselves, and 150,000 people used the World Trade Center subway stations daily. And the students. In this area were at least 50 schools from lower grades through high school, as well as numerous colleges and trade schools. Just a note that we talk about 9/11 referring to sort of the event of the day, but it's also important to remember that exposure actually extended for months and months and months afterwards as well. One of the things that is notable about the 9/11 attack was that it was both a psychological and an environmental disaster. Today, I want to review some of the psychological exposures. Acute exposures would include things like fear of one's death, during the escape, during buildings collapse, in escaping from the dust cloud itself, witnessing death. Chronic exposures would be things like loss of loved ones, colleagues, friends, the noxious smells, images of destruction, and hearing the bell that was rung upon discovery of remains. And what are the mental health conditions that are considered to be associated with exposure on 9/11? What we refer to as certifiable conditions. These are conditions that are considered to be plausibly caused by or exacerbated by 9/11 exposure or its aftermath, based on similar exposures in prior research. The mental health conditions, which are considered to be directly related to 9/11, include PTSD, depression, anxiety, substance use disorders, adjustment disorders, and also certifiable are conditions related to a medical condition or its treatment that is related to exposure. For example, a depression that's related to a World Trade Center certified cancer or to that cancer's treatment. And now I'm going to pass the baton over to Dr. Haugen.
Thank you so much, Dr. Rosen. Can you hear me okay?
Yes.
Okay, great, thanks. So I'm going to be speaking about trauma and stress-related disorders with a focus on PTSD in particular. But before moving forward, I want to spend a little bit of time introducing a few concepts. We know that stressors exist on a continuum, ranging from positive events like a promotion at work, a wedding, or even taking a vacation, to more negative or distressing experiences such as relationship problems, unemployment, divorce, or financial difficulties. Our response to stress is a combination of physical reactions, thoughts, emotions, and behaviors. And at the far end of this negative end of the stressor spectrum is traumatic stress or trauma. Trauma is a more severe type of stressor, and it is almost always harmful. And the risk of exposure to traumatic stress has been part of the human condition since we evolved as a species. Attacks by saber-toothed tigers, Achilles' loss of his dearest friend in the Iliad, or terrorist attacks have probably produced similar psychological sequelae in those exposed throughout our history as a species. And of course, traumatic stress can result in several types of psychological disorders, which we'll be speaking more about in a moment. All right. First, I'd like to point out that although many adults exposed to traumatic events do go on to develop diagnosable psychiatric conditions, most do not. In fact, across many different types of potentially traumatic stressors, research has found that the most common clinically relevant pattern of response is termed resilient, meaning that there's a stable psychological and physical health from before to after the PTE or potentially traumatic experience. The second most common trajectory is recovery, in which the exposed individual develops a set of post-traumatic reactions, which then remit spontaneously. And the most infrequent outcomes are delayed onset and chronic. And it's individuals in these latter two trajectories, which we'll be discussing moving forward. Excuse me. I just want to point out briefly the gray highlight in the middle of the figure on the right. I'm going to revisit this later when we speak about subthreshold PTSD. Okay, your poll question number 2. If you take a second to respond to this. So the question is, PTSD is a serious, often debilitating disorder that can be characterized by, and you need to select the best answer here. We have number 1 is intrusive, involuntary, recurring thoughts or images of a traumatic event. 2, persistent avoidance of stimuli associated with the event. 3, negative changes in cognition and mood. 4, marked changes in states of arousal and reactivity. Or 5, all of the above. So, although almost any disorder might follow in the wake of a potentially traumatic event, in 9/11 affected individuals, as Dr. Rosen mentioned earlier, PTSD is the most frequently occurring mental health diagnosis. So PTSD is a complex condition that involves alterations in various physiological and psychological processes. It's associated with functional and cognitive impairment, psychiatric and medical comorbidities, and increased mortality and suicidal thoughts or attempts. And according to the APA's Diagnostic and Statistical Manual, the 5th edition, there are 8 criteria that must be met before a diagnosis of PTSD can be made. I'm going to spend just a moment talking about criterion A, the traumatic exposure. So PTSD is unique among psychiatric diagnoses because of the great importance that's placed upon the etiological agent, the traumatic stressor. In fact, one can't make a diagnosis of PTSD unless the patient has actually met this stressor criterion, which means that he or she has been exposed to an event that is considered traumatic. Clinical experience with PTSD has shown, however, that there are individual differences regarding one's capacity to cope with catastrophic stress. Therefore, as I mentioned earlier, while most people exposed to traumatic events do not develop PTSD, others do. And so trauma, like pain, is not an external phenomenon that can be completely objectified. Different people appear to have different trauma thresholds. And although there is lots of interest in the subjective aspects of traumatic exposure, I want to be clear that events such as rape, torture, genocide, and severe war zone stress are experienced as traumatic by nearly everyone. Okay, so moving on to cluster B. So in order to diagnose PTSD, an individual must have at least one symptom from this cluster. Typically, these are termed re-experiencing symptoms, and they include flashbacks, nightmares, and other memories of the traumatic event. These symptoms can cause physical reactions like sweating or a rapid heartbeat. From cluster C, the individual must have at least one symptom from this cluster, which is sometimes termed the avoidance cluster. So people with PTSD may avoid places, people, or situations that trigger bad memories, and they may also avoid thinking about or talking about the event. Finally, in cluster D, which is negative alterations in cognitions or mood, the individual must have 2 or more symptoms from this cluster. So the symptoms can include negative thoughts about oneself or the world, and people with PTSD may have difficulty trusting others and feeling happy. Finally, cluster E, these are termed hyperarousal symptoms. The individual must have 2 or more symptoms from this cluster, and these symptoms include constant feelings of stress, anger, and irritability. People with PTSD may feel jumpy or get easily startled by ordinary noises or movements. And finally, these symptoms need to have been present for at least a month. They must cause either significant distress or impairment, and finally, not due to any other causes. Okay, next slide. Can you hit the next slide? Thanks. So I mentioned briefly earlier subthreshold or partial PTSD. So this is a clinically significant presentation that's found in trauma-exposed populations, including 9/11 affected individuals. and it refers to folks who at the time of assessment have some but not all of the symptoms required for a diagnosis of PTSD. There have been a number of studies that have documented that in these individuals, despite not meeting full criteria for PTSD, they commonly experience quite significant distress and long-lasting functional impairment. Some subthreshold or partial PTSD isn't a formal diagnosis in the DSM or the ICD systems, but in the World Trade Center program, which uses the ICD-10, we will typically use anxiety disorder unspecified to diagnose subthreshold PTSD for program certification purposes, or if using the DSM-5, the diagnosis would be other specified trauma and stressor-related disorders. Returning briefly to the gray zone that I mentioned in the trajectories figure from earlier, when meeting with any individual just at one point in time, based on the exposure and symptoms alone, you can assign them a diagnosis of partial or full PTSD, but it can be quite difficult to know which trajectory might be most applicable, especially given that the symptoms of PTSD, similar to other psychiatric disorders, can have a waxing and waning course, which brings us to a discussion of prevalence, trajectories, and risk factors for PTSD. Okay, so a few preparatory comments. First, regarding prevalence rates, there's significant variability in prevalence rates by cohort in the 9/11 affected population, and I'm going to be highlighting the major contrasts where they exist, but not all of them. The information presented on this slide is largely, but not totally, excerpted from a systematic review that was conducted in 2018 by Lowell and colleagues. You can see the site at the bottom there. And finally, for context, the lifetime prevalence of PTSD in the general US population is between 5 and 10%. Okay, so first, to focus on responders. In studies of 9/11 exposed traditional responders, rates of PTSD were estimated to be between 8 and 12% in the first 4 years. And in those studies which collected data beyond year 4, rates increased with this population. In contrast, studies with non-traditional responders, rates of PTSD by year 3 were higher initially at 24%, but in those studies which collected data beyond year 3, this rate decreased through year 8. In New York City residents, rates of PTSD were 5% in 1 year, decreasing by year 2. In New York City children, rates were 30% in month 4, again with substantial decreases by year 2. And within the survivors program, which I need to mention includes exclusively individuals who are self-referring for treatment and have at least one World Trade Center related condition. The rates of PTSD initially were between 38 and 41%, but moving up to year 15, those trajectories declined over time. And finally, the registry population, a large New York City cohort, showed rates of PTSD at 25% in year 7. So in summary, while most longitudinal studies show a substantial impact in PTSD for 9/11 affected individuals, over time, prevalence rates decreased for all groups, with the exception potentially of traditional first responders, who may have experienced increases over time. Okay, next slide. What makes some 9/11 affected individuals more vulnerable to developing PTSD? There are a number of studies that address this topic, which I'll provide some additional information on in a moment. But I know this is a busy slide, so I want to note that the top line finding here is that most exposed individuals remain PTSD-free, but PTSD was more likely to occur in the subset of individuals who had psychiatric vulnerability and who had more intense exposures. Okay. So I've organized the main PTSD risk factors here by whether they occurred prior to exposure, during the exposure, or in the aftermath of the trauma. There are individual studies which include additional factors specific to a single cohort. So for instance, an avoidant coping style can be a risk factor for PTSD in first responders. But for the sake of brevity, I've focused on the most well-established findings in this slide. So in regards to pre-traumatic risk factors, so individuals with a history of trauma, such as childhood abuse, previous disasters, military combat, were more likely to develop PTSD after 9/11. Those with the history of mental health conditions, such as anxiety, depression, or previous episodes of PTSD, were also at higher risk of developing PTSD. There are demographic factors. Women exposed to 9/11 more likely to develop PTSD than men, possibly due to differences in coping styles, social support, or biological factors. Younger individuals were also more likely to develop PTSD compared to older adults, potentially due to less developed coping mechanisms or resilience. And finally, socioeconomic status. So individuals with lower income, education, or employment status were more vulnerable to developing PTSD. They might have had fewer resources to cope with the aftermath. Moving into paratraumatic risk factors. So individuals who were directly exposed to the traumatic events at 9/11, such as witnessing the collapse of the towers, seeing injured or deceased individuals, being caught in a dust cloud, had a higher risk of developing PTSD. The closer individuals were to the World Trade Center during the attacks, the greater their risk of developing PTSD. And those who were present in Lower Manhattan or inside the buildings at the time of the attacks also experienced more intense trauma. First responders, rescue workers, and volunteers who participated in the rescue and recovery effort had prolonged exposure to trauma and hazardous conditions, which increased their risk of PTSD. And finally, those who lost family members, friends, or colleagues in the attacks also faced an increased risk of PTSD due to the compounded grief and trauma. Individuals who felt a significant sense of threat to their lives during the attacks, whether it was real or perceived, were more likely to experience intense trauma reactions leading to PTSD. And those who felt unable to escape or protect themselves during the attacks experienced greater distress, which also increased their risk of PTSD. Individuals who were physically injured during the attacks were at higher risk. Physical injuries can serve as a constant reminder of the trauma, which can intensify psychological distress. And individuals who were exposed to toxic dust, debris, or smoke, which led to respiratory or other health problems, are at increased risk. And finally, firefighters, police officers, paramedics, construction workers, and also mental health professionals, medical personnel, and others who provided care for survivors and responders faced a higher risk of PTSD due to their exposure, potentially to trauma-related stories, vicarious trauma, and even burnout. Okay, moving on to post-traumatic risk factors. So individuals with limited social support or those who experienced a lack of understanding or assistance from family, friends, or the community were at increased risk. Individuals who face job loss, financial difficulties, or housing instability as a result of the attacks were at increased risk. Continuous exposure to reminders of the attacks, such as anniversary events, media coverage, or sounds like sirens, things that occur in the city, can also act as triggers, increasing the likelihood of developing PTSD. And finally, those who had high levels of media consumption. So individuals who repeatedly watched distressing images and videos of the 9/11 attacks on television or online had a greater likelihood of developing PTSD. Okay, next slide. Okay, comorbidities. So one of the most robust findings in the study of PTSD, both in the general population and in 9/11 affected individuals, is the high rates of comorbidities with other medical and psychiatric disorders. The most common disorders to overlap with PTSD in a World Trade Center exposed cohort are depression, anxiety disorders, substance abuse, and suicidality. I'll say something more about suicidality in just a moment. PTSD has also been found to be associated with many medical conditions. For example, inflammation markers, cardiovascular disease, stroke, diabetes, asthma, and cognitive impairment. Next slide. The association between PTSD and mortality. So studies suggest that individuals exposed to 9/11 who develop PTSD have higher overall mortality rates compared to those without PTSD. This risk persists even after adjusting for factors like age, sex, and pre-existing health conditions. There is a strong association with cardiovascular disease. The chronic stress and hyperarousal and inflammation associated with PTSD might contribute to the development and progression of heart disease, hypertension, and stroke. Some studies have found a modest association between PTSD and cancer-related mortality. Although the exact mechanisms aren't fully understood, chronic stress and immune system dysregulation may play a role in increasing cancer risk and mortality. Also, there's an association with respiratory problems, including asthma and COPD, which might lead to higher rates of respiratory-related mortality. And as I mentioned earlier, PTSD is a significant risk factor for suicide. And 9/11 exposed individuals with PTSD have higher rates of suicidal ideation, attempts, and completed suicides compared to those without PTSD. Okay, so I'm going to move on to a discussion of the evidence base for the treatment of PTSD in this population. But I just want to note that Dr. Rosen is going to be discussing screening for PTSD later on in the presentation. Okay, so the evidence base for the treatment of PTSD related to 9/11 is somewhat sparse. To the best of my knowledge, there have only been 4 controlled trials of this population. You'll see those in front of you. In the sole treatment study, which focused exclusively on rescue and recovery workers, DeFede and colleagues in 2007 found that symptoms significantly improved for patients who received a form of prolonged exposure treatment, which we'll talk more about in a second, as compared with treatment as usual. However, there was also a relatively high dropout rate for this trial compared to other ones. This is 40%. So the remaining 3 studies pooled workers and survivors. So again, in 2007, again, DeFede and colleagues conducted a pilot study with 17 participants looking at the efficacy of virtual reality exposure therapy versus a wait list. They found some evidence that VR may be an effective tool for exposure, particularly with folks who had previously had difficulty with imaginal procedures and other treatments. In 2012, Schneier and colleagues studied 37 patients and found that PE plus an SSRI, paroxetine in this case, was more efficacious than PE plus placebo. And finally, just this year, Feder and colleagues compared an internet-based therapist-assisted psychotherapy for PTSD to an active control intervention in a relatively large sample of both survivors and recovery workers. It was 105 folks enrolled. Not everyone was diagnosed with PTSD, and there were significant reductions in symptoms, but they occurred at similar levels for both the internet-based therapy and the active control. So in short, the evidence base is sparse and not sufficient for evidence-based recommendations, specifically for this population. So I'm going to provide some more information about evidence-based therapies for PTSD in a civilian population. Next slide. Oh, you're there. So I'm not there. All right, so having a familiarity with the core treatments for PTSD can help PCPs guide patients towards appropriate treatments and also improve collaborations with the mental health professionals who are administering the treatments. So first-line treatment recommendations for PTSD are really for variants of what's called CBT, or cognitive behavioral therapy. So CBT is a widely used therapy that focuses on identifying and changing unhelpful thoughts and behaviors related to trauma. There are a couple specific forms of that have been widely studied. One is cognitive processing therapy, or CPT. It's a form of CBT that helps patients address and modify unhelpful beliefs about the trauma, which reduces the impact of distressing memories. And then I mentioned several times prolonged exposure, PE. This is a treatment that involves repeatedly confronting trauma-related memories, thoughts, and situations in a safe environment, which helps reduce the power of trauma-related triggers over time. Next, we have EMDR, which is a structured therapy that involves recalling distressing memories while simultaneously focusing on external stimuli, such as guided eye movements, to help reprocess traumatic experiences. And finally, we have TFCBT, trauma-focused CBT, which is found to be particularly helpful for children and adolescents. And this treatment combines trauma-sensitive interventions with CBT principles to address trauma-related symptoms. So most practice guidelines agree that one of these approaches is a first-line recommendation for individuals with chronic PTSD, but oftentimes as an adjunctive treatment, medications or pharm can be helpful. Where studied, SSRIs have been found to be supportive of folks with PTSD, and even prazosin sometimes for nightmares. But again, first-line treatment recommendations are for one of these psychosocial interventions, either alone or with medications, and then medications would be considered a second-line intervention. Okay, next slide. So just a few things at a high-level pass about how these treatments work. So most of these treatments involve at least one of the following three elements. The first is trauma processing. So most PTSD psychotherapies involve processing the traumatic experience in a safe and structured way, which helps patients gain control over intrusive thoughts, memories, and triggers. They might involve behavioral techniques. So for example, PE gradually exposes patients to trauma-related memories and situations, helping them reduce avoidance behaviors and build resilience. And finally, there's cognitive restructuring. So interventions like CPT can help patients identify and challenge distorted beliefs or thoughts about the trauma, which promotes healthier thinking patterns. And as I'm sure you know, when discussing treatment options with patients, it's always important to consider their preferences, their comfort level, and their readiness to address their trauma. It's also critical, I think, to normalize the use of psychotherapy and to address any misconceptions or fears they might have about engaging in a trauma-focused treatment. So Dr. Rosen will be returning to this topic in a bit, but with that, I'm going to turn it back over to her.
Thank you very much. So now, adjustment disorders. For a diagnosis, the first required element is, again, a stressor. And then symptoms develop. The patient experiences distress. But unlike PTSD, which states clear criteria for what constitutes a traumatic event, adjustment disorder does not specify what constitutes a stressor. The event can include traumatic events as well as non-traumatic stressful events such as interpersonal conflict, death of a loved one, unemployment, financial difficulties, illness. Also, in contrast to PTSD, adjustment disorders can be diagnosed immediately after a stressor, but they must develop within 3 months of the start of the stressor. So we have a stressor. It doesn't need to be traumatic. So what makes this a disorder rather than just response to life? Well, the response is somewhat out of proportion to the severity or the intensity of the stressor, even taking cultural context into account. The context of the individual's cultural setting should be taken into account in making the clinical judgment of whether the individual's response to the stressor is maladaptive or whether the associated distress is in excess of what would be expected. And for it all to have any clinical meaning, there must be impairment in social, occupational, or other areas of functioning. For example, decreased performance at work, in relationships, school, etc. And just a few of the subtypes. It can be with depressed mood, with low mood, tearfulness, hopelessness, or it can be with anxiety, which is largely characterized by nervousness, worry, separation anxiety, and there's also a mixed subtype with both of those. Adjustment disorders in the general population are associated with increased risk of attempted and completed suicide. So they're very important. It's very important to consider this. When would we make a diagnosis of adjustment disorder associated to 9/11 exposure? Well, we're no longer making a new diagnosis of adjustment disorder related to the event of 9/11 itself. Why is this? The main reason is that part of an adjustment disorder's criteria is that it does not last longer than 6 months after the end of the stressor. So if we have a patient who's having symptoms of depression about 9/11 itself, this many years after 9/11, that would not be diagnosed at this point as an adjustment disorder. But we actually use this diagnosis extremely frequently, more and more as time goes by, because we use it to describe symptoms of depression or anxiety related to a 9/11 certified medical illness or its treatment. For example, someone could be diagnosed with an adjustment disorder if they have low mood, tearfulness, and hopelessness in the context of their 9/11 related cancer or related to the treatment of this cancer. And importantly, adjustment disorder in the general population as well is very, very prevalent. It's a major accompaniment to medical illness. There's not a great deal of research on the prevalence of adjustment disorders. This may have to do with a few factors. What constitutes a stressor is hard to define. This is a disorder in which there must be an external event in order for it to be diagnosed, but that event can be at the level of a traumatic event, or it can be a stressor at any level, and cultural context must be considered. So it may be highly underdiagnosed by some clinicians or overdiagnosed by others, and therefore it can be hard to measure. In addition, it's a diagnosis which, by its definition, resolves within 6 months. After 6 months, it's called something else. So the transient nature of the illness also makes it one that's not very attractive to researchers and funders. But here is some information. Adjustment disorders are common, although prevalence may vary widely based on the population studied and the assessment method that's used. General population studies have found 2% prevalence. The percentage of individuals in outpatient mental health treatment with a principal diagnosis of an adjustment disorder ranges from approximately 5 to 20%. And in studies of CL psychiatry, or in other words, psychiatry assessments of medical patients in a hospital setting, the rates have been found to be 20 to 30%. Search results yielded nothing that I could find on adjustment disorder numbers in World Trade Center populations, but I did do a little quick look at the World Trade Center environmental health population. That's my clinic, and we found that 7% hold an adjustment disorder certification. That seems somewhat low, perhaps, for an entirely ill patient population. But remember, this is a cross-sectional diagnosis. If patients came to us for certification 6 months after the stressor ended and still had symptoms, we wouldn't call it an adjustment disorder. And similarly, if patients received an adjustment disorder certification at the time they presented for evaluation, but the distress lasted beyond the 6-month mark, a little hindsight might have helped because their symptoms would no longer be classified as an adjustment disorder. But a population prevalence that's very relevant for our folks is that of those with cancer. A 2011 meta-analysis found prevalence rates of 15 to 19% in oncology settings. It's very important to note that adjustment disorders can complicate the course of illness, decreasing compliance with treatment, potentially prolonging hospital stays as well. You might find it interesting that only up to 20% who have an adjustment disorder in that context of cancer treatment, it's only 20%. Why not 100%? Well, people are resilient in many different ways. And there are a lot of ways to be resilient. Some people may have very good coping skills. Some may have very strong support systems. And some may, frankly, be in denial. Denial can, at times, be very protective. It might get you to treatment rather than staying in bed. And then there's also, of course, measurement error, right? So there's a possibility that people are not understanding the measurement. People might not be answering honestly, that type of thing. So there are many factors to consider here. We're going to talk about assessments in just a bit, but first we're going to talk about treatment. There's not a lot of good evidence on treating adjustment disorder, and therefore there's no clear treatment recommendations. There is a 2018 systematic review of treatments available by O'Donnell and colleagues looking at 29 psychotherapy and psychopharmacology treatments. They found the quality of the evidence in these studies to be from low to very low, mostly because of the lack of consistent, reliable measures of adjustment disorder, small sample size, and lack of follow-up assessments. Nevertheless, people really suffer when they have adjustment disorder. And since there's also a risk of suicide, clinical monitoring and interventions are indeed recommended. Small positive effects have been found for various pharmacological interventions like SSRIs to help people with debilitating symptoms of depression, anxiety, panic attacks. Helping treat somebody with chronic insomnia can also be helpful. There's some evidence supporting technology-assisted cognitive therapy and psychodynamic therapies aimed at reducing the stressor, improving coping skills, and reinforcing the individual's support systems. So we'd like to talk about what this all means for you. The prevalence of psychiatric conditions this many years after 9/11 suggests that we do need to continue to screen for mental health issues and point folks towards treatment when appropriate. Primary care providers, excuse me, serve a key role in evaluating, treating, and referring patients who have 9/11 related psychiatric symptoms. So we want to talk about some interesting considerations. We want to talk about screening patients, treating a little bit, and we want to leave you with some helpful thoughts. A lot of the presentation offered hard facts about PTSD generally, some specifics about those exposed to 9/11, but we want to describe some interesting, somewhat unique presentations in these populations so that you might recognize them when you see them. Research has suggested that PTSD can present in a few different ways, and in fact, there are a few different subtypes. The first, a hyperarousal profile, which is the most recognized one, what we think of when we think of somebody who has PTSD, and the way that anecdotally, most of the survivor cohort tend to present when they are in treatment is alert, always on edge, sort of this anxious arousal. Interestingly, clinicians seeing responders as well as research suggest that the responders tend to present with another subtype profile, a dissociative profile. The dissociative presentation involves a persistent avoidance of distressing emotional states and dysphoria, blunted affect, the blunted affect is one of the main prominent features, as well as a sort of dysphoric arousal, irritability, sleep disturbance, concentration difficulties, and the presence of these symptoms generally is what tends to lead to the numbing over time. These folks tend to be shut down and angry. Here's some common story profiles we see both in responders and in survivors. The first is a group of patients who function extremely well for years and years, then face a 9/11 related stressor, for example, cancer, or a non-9/11 related stressor, such as retirement, and have full-blown PTSD reactions as a result, as though out of the blue. You might be seeing patients for years and not even know that they were exposed to 9/11. Then a stressor comes up in their life and they're no longer able to cope. A change in functional presentation might prompt you to make an inquiry. We also find a significant interplay between 9/11 related medical illness and 9/11 related psychiatric issues. Noted earlier, 9/11 related illness is highly comorbid with 9/11 related psychiatric illness, and an exacerbation of one tends to lead to an exacerbation of the other. This seems intuitive. Person's physical health worries, sure, and could cause anxiety and depression. But some of the less directly related symptoms might also get exacerbated. For example, hypervigilance, fearfulness, being easily startled, or avoidance. Stigma refers to negative attitudes about mental health conditions which can keep someone from seeking care. There are different kinds of stigma, and in fact, they can all play a part in an individual's experience. Public stigma involves the negative or sort of discriminatory attitudes that others may have about mental illness. This can plague members of certain communities. For example, in the survivor cohort, members of some Asian and Black communities experienced feelings of shame or weakness about having struggles, the result of cultural norms. Self-stigma refers to the negative attitudes, including internalized shame, that people with mental illness may have about their own condition, which also is, connected to the first one I was mentioning. But this is often experienced by first responders who may believe that they should be able to deal with difficulties without it impacting their emotional state. Structural stigma is sort of a more systemic stigma involving organizations, jobs, government, et cetera, that intentionally or unintentionally limit opportunities for people with mental illness. First responders sometimes feel a lack of support from work organizations, superiors, and colleagues. A study in which Dr. Haugen was an author looked at stigma in 12,000 responders and found that police responders, as opposed to non-traditional responders, were fearful of negative job impact should they seek help or disclose the need for help. In the survivor population, we encounter members who don't want to disclose mental health symptoms or their need for support for fear of being denied future work opportunities, fearing that their mental health status is of interest to future employers. How can you help with stigma? Talking openly about mental health, sharing facts and experiences, normalizing treatment, showing compassion about the topic. Also, something can be very helpful is drawing comparisons between physical and mental illness, asking them how they might feel or think about somebody who has a medical illness, such as diabetes. Okay, screening instruments. So the gold standard is something called CAPS, which is a very, very complex, long structured interview. In the program, we tend to use a clinical interview as long as a screening instrument known as the PTSD checklist, which it has 20 items associated to DSM-5. And if you have time in your waiting room, we do suggest using it. It's a really, really good instrument that can sort of give a diagnosis of probable PTSD. But that said, moving on to short screeners. On the VA website, you can find some screeners. We are also going to be attaching in the chat a couple of screeners, both for PTSD and for adjustment disorder. There is the primary care 5, which was built for use in primary care settings. It has 5 questions, different scoring a little bit for men and women. There's also the abbreviated PCL, which has 6 or 2 items. The 6 is a little bit better. 14 or greater is positive. It's always recommended to follow up with an interview or with the PCL 5. There is no gold standard for adjustment disorder, but there's something that is called the International Adjustment Disorder Questionnaire. It is very easily worded, and it's slightly annoying to score, but it's not difficult at all. That's another thing to consider using. Again, all these are in the public domain, and we put them in the chat. Okay. So wrapping up, we're getting towards the end here, what to do and when to do it. Hopefully this will help you a little bit, knowing what to do. So you're going to want to screen patients when they report exposure, when they have psychiatric symptoms, have risk factors. You're going to treat patients when you feel comfortable prescribing an SSRI, and that seems like the appropriate thing for them, or when you're, prescribing perhaps sleep agents. Many med providers do feel comfortable doing so, which is great. Refer patients when there is comorbid substance use disorders, comorbid medical issues, when medication seems to veer into unfamiliar territory for you, if it seems like it's very complex, or if there are new medications that seem to be appropriate for that particular patient. You would want to also refer if your patient is a member of a very high-risk group after a very significant stressor. If somebody's functioning becomes highly compromised, if you're concerned for self-harm or suicide, if there's diagnostic uncertainty, or if a patient seems ready to engage with psychotherapy. Okay. We used some clinical best practice guidelines. You can find them online as well for the survivor population. We like the APA guidelines. For the first responder population, we like the VA guidelines, which was developed for veterans and often overlaps very nicely with the needs of responders. Just to conclude, many years after 9/11, 2001, people are still suffering from mental health conditions. And medical providers play a crucial role in the screening, treatment, and referring of patients. And go ahead and consult best practices when needed. Thank you very much. And we'll take any questions.
All right. Thank you, Dr. Rosen and Dr. Haugen. I think I forgot to mention who I was. I'm Dr. Jeff Calvert. I'm with the World Trade Center Health Program. And also helping us in the background is Kiana Harper, who's with the NIOSH Office of the Director. And so we did get a couple of questions. So the first one is, and these are from earlier in your presentation. So the first question is, what is the latest research on videos of or TV viewing of the trauma of on the exposure criterion?
Hi. So this actually isn't my area of expertise, but there is a page that looks relatively recent that the National Center for PTSD maintains on this topic that describes the literature regarding 9/11 that I mentioned, but also some literature on the Oklahoma City bombing and media viewership, and also provides a tip sheet, both for adults, but I think it's really focused on how to manage kids' consumption of media after disasters or other types of difficult events. So I've put that link, I think, in the chat, so hopefully you can see that. And Dr. Calvert, should I can try to respond to the second question.
Okay, I'll read it.
Okay.
So the second question is, how about supervisors of others? Are they at increased PTSD risk?
It's a great question. I supervise folks in the treatment of PTSD, so it's certainly something that I've thought about. Again, not my area of expertise, but to the best of my knowledge, I'm not aware of any systematic empirical research on this topic, but it certainly is part of, I think, informal clinical best practices, both to be able with our supervisees to think about vicarious trauma, and also to look for signs of that in ourselves. And I think that the same tips and tricks apply, whether it's with supervisees or with yourself as a supervisor, looking for signs of burnout, making sure that you're consulting with colleagues, engaging in self-care, things like that. But if others may know more than I do, but I'm not aware of any systematic empirical research on the topic, but it's an interesting question.
So if other people have questions, feel free to type them into the Q&A box. But while we still have a few minutes, so maybe I'll ask a few questions. So both of you have experience treating persons with PTSD, and I'm wondering, what's the prognosis for people with PTSD, and how often do you get a cure?
I'm happy to give my answer to that. And Dr. Rosen, I'm curious what you would say. I think in the the evidence base for PTSD treatment, certainly suggests that treatment can be quite helpful. And a large number of folks who engage in one of these first-line treatments and complete the treatment can no longer meet criteria for PTSD at the end of the treatment. That having been said, it's difficult stuff, and patients oftentimes, completely understandably, may have difficulty even finding a provider who provides these treatments, feeling like sufficiently hopeful about the benefits they might get from treatment to really fully engage, and then being able to stay in treatment is also something that can be quite difficult. So I think engaging patients throughout the course, both before treatment and during treatment, is incredibly important. And the better that you can do that, the more likely patients are to have significant benefit in regards to both symptoms and impairment. But like all of our psychotherapeutic interventions, I think the interventions we have are quite good, but they are not going to be helpful for everyone. And so, in my opinion, I think being familiar with more than one first-line treatment approach, given that we know that any approach will fail a certain number of people, I think is quite helpful for clinicians. But in general, I'm very confident in our ability to provide some support and some comfort for folks in treatment. And then there's a lot of work for us and on the part of patients to make sure that we're meeting them where they're at, and they're able to stay in treatment and do the work. Dr. Rosen, curious. Yeah.
So yeah, I love what you said. I totally agree. Meeting people where they are is, I think, very important, because you want people to stay engaged and to continue. Otherwise, they're not going to be helped at all. A couple of things to note is that one thing to note in particular is that even when people are treated successfully and they feel for the most part that they're able to function quite well in their lives, there are things that will bring back symptoms, anniversary reactions, other things may go on with their life. They may have a resurgence of symptoms, and that's something to know. And it doesn't mean that those resurgences will last forever either. But that is something to understand will happen. I also want to just extend what you were saying a little bit further, Dr. Haugen, which is that I think that we have patients who come in with unrealistic expectations in that they want to feel exactly like they did before the trauma. And in other words, and when you ask them sort of what that means, it means that they want to pretend, they want to be as if the trauma never happened. And unfortunately, that's not the way that life works. The trauma is always going to be part of a person's history. And part of the treatment, I think, is coming to that understanding. And hopefully through the treatment, a person's able to integrate it into their life story in a way that doesn't feel oppressive and doesn't feel like it is controlling you, rather that it's part of your story. You may not want to always revisit it. You may revisit it when you feel comfortable doing so. But it is important, I think, for patients to have that expectation managed, that they're going to feel as though nothing ever happened.
All right, so we're pretty much out of time. Dr. Rosen, would you mind stopping sharing? And I want to thank both of our excellent speakers for a very interesting presentation. Thank you so much. And now I'm going to talk about getting the CE credits. I would recommend that you take a screenshot of this screen. Okay, so yeah, take a screenshot of this because it's a little complicated to get the CE credits. So what you do is you'll go to the CDC Train website. You could just Google CDC Train and it'll come up. Once you're on that website, you'll need to log in. You'll need to create an account if you don't already have an account. And then once you're logged in, you'll need to find this course, this webinar, which the easiest way to do that would be to type in WC 4740. And then it'll ask you for an access code, which is the World Trade Center Health Program. And if you're watching the recording, instead of typing in WC 4740, to find the webinar, you would type in WD 4740. Then you'll be asked to select the type of CE credit you're requesting. Then you'll complete the course, which you've done here, the folks who attended this live version. Then you'll select the Mark Completed button, which will then move you to the post-test, and you'll have 2 attempts to pass the post-test. It consists of 4 questions. You'll need to get 3 of those, at least 3 of those correct. Then you'll be asked to take an evaluation, and then after that, you'll have an opportunity to download your transcript with your credits. So with that, it's pretty much time. We're out of time. Thank you so much for attending, and thank you to our speakers. Thank you to Kiana Harper, and I wish everybody a wonderful rest of your day. Thank you.